everyone. Welcome to the 209th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Sònia Travé Huarte. Dr. Sònia is originally from Spain, but currently at Aston University, where she is a postdoctoral researcher and an optometrist there. Her specialty areas are in dry eye diagnostics and treatment, anterior ocular surface disease management, as well as specialty contact lenses. She has done a lot of work in the topic which she's going to talk today with us, that is the Meibomian glands. And she's also a clinical supervisor on the optometry program at Aston University. More recently, she also delivered the Irwin Fatt Memorial Lecture at the British Contact Lens Association Conference. And she also is a chair of the fellowship committee of the BCLA. She holds a couple of fellowships onto her credit, in education, a fellow of the BCLA as well. And, her most of the time, I would say, goes around researching about treatments, innovations, and, looking at best evidence-based treatment care for the patients she sees. So welcome, Dr. Sònia, onto our platform. And thank you so much for sharing your Sunday afternoon with us, going with Meibomian glands and its treatment. And let me just leave the screen time to you.
Perfect. Well, thank you very much for that wonderful introduction. Hopefully you can all see my screen. So I'm going to start talking about Meibomian glands, how to image them, how to understand the lids, all the surrounding tissues, what's healthy, what's unhealthy, and the different treatments that we have. We're going to start just with a quick introduction about a normal anatomy of the gland, what a Meibomian gland, what a dysfunction is, and how much of an impact that could have to the ocular surface. And then we're going to go through some imaging techniques, tools, devices, and diagnostic tools that could help us towards understanding a bit more about that patient and that condition. And then we're going to move on to treatments. So without any further ado, we're going to start with the anatomy of the glands and the lids. So we have about 30 to 40 Meibomian glands on our lids. We have on our bottom eyelid and on the top eyelid, and they are put on a very sort of parallel manner, and they go from all the way to the bottom to the top and the other way around. Their secretion, the meibium, what they produce, is released after every blink, and what it does is it goes on top of the tear film to prevent it from evaporating. So it's very, very important, it's key actually, that the outputs of those glands, they lay on top of the tear film. And because of that, we'll show you later how the openings of those glands are sitting. So the Meibomian glands, they have clusters of acini, which are like those round areas that you see here on the sides. And that's where they produce the oil. So we have meibocytes, so they produce the meibium. And that is influenced by either hormonal and neuronal regulation, but also by the pressure of the muscles that we have around. So the meibium is created on those little acini, and then by those small ductules, it's brought into the main duct. And that's when then it gets expressed going all the way out by the opening of the Meibomian gland. And then it is expressed and spread around the lid and onto the tear film itself. And the way that it works is we have forces. When we blink, we have a force, sort of like a horizontal force from that muscle that is pressing and compressing and helping those oils flow up. And then as we blink, we also have that sort of like squeezing motion from the orbicularis muscle. So that's what helps the oils to flow up. So a very important thing in here is how those glands open up. Therefore, we have here an explanation of how a lid looks. So looking at this graph, this figure that we have in the left, we can see here that the black drawing, that's a Meibomian gland, and the dots all along the lid, they are the openings. So behind that, we have the mucocutaneous junction, which separates the skin tissue, the keratinized tissue, the cornified tissue, from the mucocutaneous tissue inside. That line, that separation, is called the Marks line, and we can see it with listamine green dye, which we'll show you later on. And then more anteriorly to the openings, we have the gray line, which is the where the Ryland muscle sort of inserts into. And then if we move even further, more advanced, we then have the lashes. That is very, very important, having this distribution as it is, because the tear film, as you can see in here, you have the different layers. So you have the mucus layer, mucoicutaneous layer, which is closer to the cornea. And then at the very top, you have the oils. Therefore, the openings of those glands need to be more anteriorly placed than the junction or the Marks line, because the oil needs to be put sort of like on top of that layer. What would happen if those openings are moved back more posteriorly, or that junction is moved more anteriorly? What would happen is that those oils would effectively not be on the top part of the tear film. It would be mixed onto the ocular surface tear film. Therefore, those oils would not have that spread and that same protection that they would if they would be placed in the right position. We have an example here. What happens when either the line, the Marks line moves, or that the glands, sort of like the openings, moved more posteriorly, which is something that can happen with aging. And in here, we have a very, very interesting picture. So normally you don't tend to see this line. You tend to see it when you have the listamine green, which we have here at the bottom part. And that is the line that separates those two tissues, the more cornified tissue at the top and the more mucus at the bottom. So that showcases this line over here, the MCJ line. And that's what can show afterwards if there's any lead wiper, but that's on the more anterior parts, or like towards the eye. What we're looking today is that light from that line onwards. Then on here, more anteriorly, we have the openings of the glands, and that's where the glands would release the output of the oils. Therefore, any issue with the lid or any changing of those opening placements, such as having an entropion or such as having any malpositioning of the lashes, could lead to having those oils spread in a different manner. So now that we know a bit about the lid anatomy, we need to understand what is the function of those oils. So first things first, the tear film, it is the first refraction that we have when the light hits the eye. So we have to make sure that it's optically smooth. And also the meibomian, when it goes on top of the tear film, what it does is prevents the evaporation of that tear film. Apart from that, it tends to increase the breakup time. Without it, everything would evaporate. And it helps in spreading evenly that lipid layer. Also, the fact of having the oils, the meibomian, spread on top of the surface of the eye, the lipid layer thickness, prevents the rest of the tear not only from evaporating, but also from just, tearing in there. The other thing that is quite good meibomian is because it's antibacterial, and it helps with trying avoiding contamination of that lipid, of that tear film. So we have on our lashes, we also have the folliculi. That's where the hair lies, our lashes, and we have the sebium. So the meibomian, what it does, it's sort of like it separates that sebum from entering into the eye as well. So all of these and a lot more protective functions, that's the idea for that meibomian. And every time we blink, that translates onto the lipid layer that goes on top of that tear film. So now we're going to talk about the dysfunction of those glands. So the workshop that was on in 2011 sort of like classified it and the dysfunction as being a chronic and diffuse abnormality of the glands. Normally, that is characterized by an obstruction of those glands at different points of the glands, and then changes onto the secretion of the glands themselves. And all of that could have an alteration onto the surface of the eye, onto the symptomatology of the patients, and the lid margin itself. So clinical signs are quite varied because there's patients that they may not feel much. There's patients that they might feel something in the eye like greed, or every patient feels sort of different sensations such as irritation. But what we see is, apart from we could have some dropout in the Meibomian glands, and as we see here in the images. So altered consistency of the oils and also some lead changes. What we need to know is that Meibomian gland dysfunction is more prevalent in Asian population, Asian demographics, and as we age, Meibomian gland dysfunction also increases. And what the patients could tell, or what we could see, is that alteration in the tear film, some irritation, and some inflammation in certain cases. So what happens within the gland itself is, as we've explained before in figure A, the oils come up all the way to the opening of the gland. But what happens is, if at some point there's a blockage at any point in the gland, the outputs of those oils cannot come up and then spread across. So what it does, it sort of like stays and it becomes stagnant within the gland itself. And because it has no place to go, it sort of, the duct dilates a bit. And as that dilates and the meibomian has nowhere to go, that's when the gland starts suffering, and then it either becomes short or there's an atrophy of the gland. So that's what's happening at the end. Again, that blockage could happen at different points. So in these figures in here, we have blockage at different distal parts of the gland. So if this is the opening of the gland, we could have blockages right quite close to the border, which would be something lead related probably, or it could happen at any other point in the gland. The issue is that once the output cannot come up, there's an increased pressure within the gland, and if the gland cannot deal with it, then it sort of like dies off. So first it dilates the ducts a bit, and then there's it sort of dies off. It could be that it's only a portion of the gland and we still have another portion of the gland working, or it could be the entire gland. So in here, now we're thinking, okay, we know that the human healthy meibomian should be clear in nature. But what's happening now is that we tend to have more bacteria, keratinized tissue inside that meibomian. And therefore, it becomes a bit more cloudy, a bit more inspissated, so a bit more viscous. The fact that we have that keratinized material within the meibomian doesn't mean that it's inflamed by nature. We could have an inflamed lid, but it's not the main factor for an obstructive NGD. So now thinking about this, I have a question for the audience. So we have this in here, we have two solutions. Let's pretend that solution A is meibomian, normal meibomian, and solution B, there's the addition of that keratinized tissue or any other things. What do we think that would happen to that substance when we warm it up? So if the composition of that meibomian changes, what do we think that's going to happen when we try and melt those oils? Will it take more temperature to melt those oils, or will it take less temperature? So if you want to scan that QR code and try and click on the right answer, then we'll see what people think. I'm going to give it probably a minute or so.
Yeah.
So one of the things that we know that is happening. Sorry, can everyone access the poll?
Yeah, I think we'll just give about 30 seconds for everyone to scan. Yeah.
So what we know is that the meibomian itself keeps changing with the patients that have Meibomian gland dysfunction, and it tends to become more viscous because we have other sort of substances within. Now we're going to see the idea. Once we have more substance or different substances within an expected substance, if we warm that up, what's going to happen? So I think we have about 21 people that voted. That's good. We're going to wait a bit more, see what people think that's going to happen. Perfect. We're going to wait until we have probably about 30.
Yeah.
Yeah, perfect. So good. most people think that the melting point increases, and that's exactly what's happening. So as we have different substances within, the melting point does increase. That is why when we explain to our patients that they need to warm their eyelids for that meibomian, that oil to come out, it needs to reach a specific temperature. That's why they cannot everyone use face cloths, because we know that that temperature will not remain at the standard of temperature, at the high temperature that we need to. We need to make sure that we use specific designated treatments, warm compresses or eye bags that will keep that temperature going for the time that we need to at the right temperature. That's why it's so important that we know about the those oils and the temperature. Perfect. So on the international workshop that was on in 2011, when they sort of did this, it was sort of a diagnostic or a flow of the types of Meibomian gland disease that we have. So working here in Meibomian gland dysfunction, we have two different stages. The one that there's not enough delivery of the meibomian of the oils, or the other one, on the other hand, when there's a high delivery stage. In the low delivery, we have where basically the glands do not secrete enough, which could be certain medications, that's also called Meibomian Zika. And then we have the obstructive type of delivery. Basically, it is obstructive because there is actually a blockage somehow, either by a scar, so cicatrizal, or non-cicatrizal, which could be other issues. And in terms of the delivery, we have hyper-secretory, high delivery. It could also be certain specific things. So now thinking about the meibomian, when we have changes on the meibomian, we have changes in the consistency, that viscosity that we said, that's why we need to warm them up, and the color. So when we express, we'll see those changes. And that actually reflects the composition within the lipid, not the amount of keratinized tissue that we have from within. But if we have an obstruction of the gland, most of the time it tends to be because that tissue is keratinized, at least on top or the openings of the glands. And what happens then is that those the secreted lipids can then be altered if there's any bacteria on the lid margin. So we have blepharitis, if we have too much of a bacterial overgrowth, that then what happens is that it breaks down those lipids, and that is what triggers more keratinization of the tissue, triggers more of a lid margin irritation. So it's sort of like a continuum, kind of. And that's why the melting point also increases. So a very important thing to be aware is the risk factors that we have to develop that. Apart from the aging that we've already said, which is a systemic thing, we have Demodex. We have any buildup of blepharitis or any buildup of microbes or biome within the lid margin. And then we also have things such as tattooing or floppy eyelid syndrome, as we've said before. If the lid is facing too much outwards or inwards, like ectropion or intropion, the openings of those glands and the oils will not be released at the right layer of the tear film. Eye surgery, contact lens wear, there's a couple of things that could increase the risk factor to develop MGD. In terms of systemically, we've already said that aging and certain deficiencies, hormonal deficiencies, could also play a big role. And in terms of medications, we know that there's medications such as glaucoma, medications for skin disease or acne that could also trigger a bit that Meibomian gland dysfunction. And then we also obviously have the environment, so the geographical factors such as temperature, humidity, and the blinking and staring at devices. There's recently a new TIFOS environment lifestyle report where they just go through all of this. That's more facing in terms of dry eye, but because dry eye Meibomian gland disease is so intertwined together, we can actually read that and you'll find all this in a lot more detail. So now we're going to talk about the impact that Meibomian glands and Meibomian gland disease has on the surface of the eye. So what we know is that Meibomian gland is actually the main cause of what is called evaporative dry eye. We know that in dry eye, sort of like a spectrum, there's no such thing as purely evaporative or purely aqueous deficiency. It's sort of like within a spectrum. But Meibomian gland dysfunction is the main sort of causative evaporative dry eye type of. And it is also, that type of oil contributes to the status of that tear film, the stability of that tear film, as we've said before. So it depends on how the gland is and how the gland secretes, not only how it looks. It's all about different contributing factors that leads to changes in the lids and on the surface of the eye. So this is a very busy slide. We're going to sort of break it down. So we're going to start by the low delivery. If we have a low delivery of meibomian onto the lid margin, we then have a deficiency of the tear film lipid layer, which is what would change therefore the breakup time, more irritation, some damaging factors for the surface of the eye. So that's if we have low delivery. On the other side, we have low secretion. And that could be because of any specific issues within the secretion or any blockages. So that blockages actually could be on both sides, on the low delivery or low secretion. And what happens when there's an obstruction is that stasis, where the oil, the meibomian, remains in the eye. We have a pressure, we then have a dilation, and then we have an atrophy, which would then lead to a dropout. All of that leads to an inflammation because that oil is supposed to be released. If that oil remains stagnant in there and there's that pressure, that releases lip acids and toxic mediators onto the surface of the eye. So all of that obstruction leads to an increased viscosity of the meibomian, that change on melting point, and possibly that keratinization of the tissue. So all of that leads to having changes both on the quality and the quantity of the meibomian released onto the surface of the eye. Other things that we can see on the lid margin, it's always very, very important. It's not only about just looking at the glands, look at the lid margin, look at the lashes, look at the lids. Is there any change? I always look at the thickening and rounding of that lid margin. Can you see that that is not regular? There's sort of like a bit of bumps in them. There could also be some notching. You could have some telangiectatic vessels, such as we have in here, blocking directly in here, or you can even have, in certain disease, keratinized tissue. That's where the keratinized tissue takes sort of like that area that is not supposed to be keratinized tissue, and therefore it blocks and obliterates that opening of the gland. We then also have changes in the secretion of the oils, as we've seen, and all of that leads to possibly ocular surface disease or dry eye. If we look more into the obstructive side, we have the cicatrizal bit. So it depends on the specific conditions. There's some skin conditions that could lead to it, and that's what changes and sort of blocks by scarring that opening of the gland. And then we have other skin conditions that could lead to that create that obstruction within the gland. So that those changes could either be at different points of the gland, as we've said, on the more distal part or the more proximal part, and it will indeed affect the secretion and the outputs of those glands. And then on the other side, we have the high delivery, when it means that there's too much secretion or it secretes all at once. So most of these patients, they are associated with seborrheic dermatitis. So you always have to look at the patients as a whole, very holistic. So I always look at their face, at their skin around the eyes. And this is key, because patients that have seborrheic dermatitis, they tend to have more production of sebum. And all of that changes the production. Also, other skin conditions such as rosacea and acne could also have an impact on Meibomian gland dysfunction. So the very important thing is that we don't know exactly why that high delivery is happening on the surface of the eye. If it is only because there's actually, the glands are truly hyper secreting those oils, or actually the oils are all concentrated, then they come all at once, so presenting an obstruction. The most important thing that we as ECP, as eye care practitioners, we need to see is that we need to know is that in high delivery states, we're not going to find major changes on structural changes on the Meibomian glands, and we may not find a lot of changes in evaporation or tear film stability. So those are things on the high delivery status. But now looking into the evaporative dry eye versus aqueous deficiency dry eye, that's from PSPHOO DUCE 2. So once we've diagnosed everything in terms of the dry eye disease, that's when we can sort of like subclassify onto where that fits. So we'll look into the evaporative dry eye. In here, what we know is that both types of dry eye, they have an inflammatory component, because we have that, in this case, we're looking at the evaporative dry eye type only, where the Meibomian gland disease plays this role of those oils will not be stabilizing the tear film as much as we want to. Therefore, we're going to have high evaporation. High evaporation will lead to high tear osmolarity, and that will lead to all these cascade of events that will then link onto that vicious circle. So now we're going to look a bit more into imaging diagnostic tests that we can do for it. So before we carry on, we have another QR code. And in here, I would like to understand a bit more of what do you do? Which are the tests that you use to diagnose dry eyes? If there's one test, you put one test. If there's 3 tests, you can write 3 tests. Normally, for me, I don't use one specific test. I use multiple tests, as you'll see later on. But there's people that have sort of priorities for one versus the other one. There's people that use they express the glands. There's people that prefer meibography. There's people that prefer using breakup time methods. So yeah, we have a lot of them coming up at the moment. So meibography seems to be quite a big one so far. So we have Schirmer's, okay. We have the breakup time, which is good. Breakup time could be done ideally non-invasively. LipiFlow, okay, so LipiFlow, that would be a treatment for Meibomian gland dysfunction. That's good. Tear meniscus height, interesting. Yeah, tear meniscus height will sort of help us to understand if it's more an aqueous deficiency type versus a more evaporative type. Breakup time again. Yeah, that's good. K5 is a device that actually does plenty of tests. We will do. We will go through these devices later on. Manual expression. Yeah, that's good. Tear meniscus height again. Yeah, wonderful. I think that having that the OOLS express does tell us quite a lot about what's happening behind the glands, behind the oils coming up. Perfect. So I'm gonna wait for 2 more people that I think that they're typing. Manual expression, tear breakup time, Schirmer test. Let's see what else we have. Meibography, breakup time, and slit lamp biomicroscope. Yeah, perfect. So yeah, actually, it's not that one of them will give you the right result. I normally take, that's why I did a workload, because I take all of these things that will help me to understand why my patient's having what they're having. So we're gonna go to, this is PSPHOO DUCE 2 workup on the diagnostic criteria. And what they said is that we need to look not only onto the tear volume assessment, but also on the lipids. So Meibomian glands, that's what they release, the lipids. So we need to look into the lipids. Lipids, looking into the lipid layer thickness, but also the output of those oils. So this is what I do. It doesn't mean that this is the right thing, but if once I've diagnosed everything, I want to go into a lot more detail about all of these things. So what I've marked in here are the things to me that they're very important. Specifically when looking for Meibomian gland dysfunction, I want to look at the blinking rate. I'll tell you why in a second. Then I always tell them to close their eyes and or to look down, and I look at that low lid, that lid margin. I want to see if there's any blood vessels, any plugging, capping, runding, notching, anything, any foaming of those lipases, any lash losses. Looking at the lashes is very important because we need to understand if it's more of an anterior blepharitis, a posterior blepharitis, a full MGD. So you need to look into all those little details. Then I tend to move on to interferometry, which is where I do an assessment of that lipid layer. And then I do more invasive tests, so always from less invasive to more invasive. And then I put the dyes just to see both fluorescein and lissamine to see if there's any damage or any displacement or any lid wiper of that marked line, or literally any keratinization that could be blocking those openings of the glands. And then in the end, I obviously do lid eversion and look into the states of the glands, not without forgetting that it's not only how they look, but it's also how they function. So we're going to go through this now. So in those two videos, you have in the right a person that does a full blink, and on the left a person that when he blinks, it's, as you can see, doesn't fully close those eyelids. And just looking at the Myers reflected there, you can see that there's already something going on. So what I'm looking here is, apart from how much they blink, because if they blink too much, maybe it means that tear film is not stable and there's something going on with those oils or those outputs. And then I also look into that full closure, because if we don't have that full closure, the lids are not pressing against each other and then releasing those oils. We may still have some oils being released, but it's not going to be as much. In the meantime, things that you can do is use interferometric techniques to look at the lipid layer pattern, which we're going to do next. But in here, those videos that I've put here, they're with fancy devices, but sometimes if you just have a camera or when the patient's doing their questionnaires for the symptoms, you just look at them and you just count how many times they're blinking within a specific time frame. Or even if you want to see a good marking of that lid closure, if you put fluorescein in, the patient blinks, but they don't blink fully, you'll see where that blink sort of finished. So that's quite good to see sometimes. So in terms of the lipid layer thickness, the lid marking features, there's a couple of things that we should be aware of. So in this case, we have in this lid, we have some telangiectatic vessels. Those vessels, I always think about those vessels such as the retina. We don't like new thin vessels because they bring inflammation. They bring things that they should not be there. So any thickening, rounding, any blocking of the glands, those are signs and features within the lids that there's something either happening, about to happen. So a lot of things that you should be in the lookout. We also have some notching in here. So that basically could be that a gland from within has a blockage and it's sort of like there's a bit of an atrophy. So it's actually pulling from within. That's when you see that bit of a notch within the lid. You can also see it by looking at the tear prism, that you'll see that there's a sort of like an indentation. And then thickening and rounding of that lid margin. Can you see that this, rather than looking at flame, is a lot more rounded than it should actually be. So all of these features and a lot more are things that you need to pay a lot of detail looking into. Blocking of the glands by hardened wax, hardened oil. So basically what we said before, the oils, once we have Meibomian gland dysfunction, they become more viscous. The more viscous, the harder it is to melt. Therefore, with the normal body temperature, those will not melt. They will block the openings or any other area within the gland, and they will prevent those oils from coming out. Other things that we have to take a look at it is that lid, that marked line, the green line that we have to make sure that it's always more posteriorly towards the eye rather than interiorly. Things can happen with aging where that where the gland sort of like the openings move a bit backwards or the marked line moves a bit forward. And if you have that marked line crossing the glands, the oils will not be delivered in the right layer of the tear film. Again, rosacea, be very looking into rosacea. So this is not the lid of the patient, but that's the nose just beside the eye. So again, always look at the patient as a whole, not just two eyeballs. Make sure that you look at everything. And a very important thing that I don't know if everyone's thinking about, but it's very important, is cosmetics. And where do patients apply cosmetic and how, and the chemicals and the nastiness of all, all of the cosmetics. So we need to be very careful in explaining and in seeing the details, because it's not always the components of that makeup. It's also when you release it, the chemicals of glues. So make sure that you talk to the patient and explain everything. So now we're just looking at the features of the lid, but also lashes, what's happening at the lashes, if there's any misdirection of the lashes, if there's any madarosis, which is lashes missing. All of this could be hints of something that's happening in that tissue that could tell you, oh, there might be something going on. And then this is interferometry, so lipid layer thickness. I normally use the modified Guion killer system. It grades from 0 to 4 to 5, starting with an open mesh-work, which is the first video that we have here, where the patient blinks, you see something, but it's very hard to see, which means that those oils are very, very thin. Moving on to, in here, we see sort of like a wave pattern. We see a bit more oils floating. That would be a 3, a wave or a flow. And then moving to this, when the patient blinks, you do see here quite a lot of color. That would be a color fringe pattern. If you don't have a K5 or a LiPV or any of those devices, you could still use your plain old slit lamp. It does pretty much everything that you need to. Just do a Purkinje one, so the scapular illumination. The first Purkinje image that you see, that is the tear film. And just ask your patient to blink and you'll see the oils floating up. And then now looking into, obviously, more the end of that assessment once we are everting. So at this point, we've already done fluorescent listamine, and now we're everting. So we have the Meibomian scale, that's by Heikopold. And in here, it's sort of like a percentage of the area of loss of those glands. And it's graded from 0 to 4, being 0, almost no amount of Meibomian gland loss, to up to degree 4, which is more than 75%. This is Meibomian scale, but there's other scales. So I'm presenting different scales. These are the scale that we have in here, is looking at how full those glands are. We could have a normal gland, which is full, sort of like this one, even though it's a bit tortuous. A gland dropout, where you actually don't see a gland, sort of like in here, in this bit, we don't have gland anymore. Or partial glands, like this one over here, where you do still see that shape where the gland is, but where it used to be sort of like all the way through the lid, you don't see that anymore. So that would be considered a partial gland. And that's the grading that, one of the gradings from ARITA, the grading from grade 0 to grade 3, also grading the loss. But in this case, they're looking at the total area of loss, again, from 0 to 3. And then there's different ways to do meibography. The most important thing is that you need infrared light. You need infrared light, and you need a sensitive device, so sensitive CCD, the camera, but it has to be infrared sensitive. Otherwise, you may not be able to see it. In this case, I'm just showcasing these images because this is done in infrared light, but we also have the transillumination, where we actually shine a light through the lid, and it shows the Meibomian gland sort of like in a reverse manner. Instead of white over black, black over white, which could help sometimes if there's any blockage or anything, just to see it a lot more clearly. And then this device, which is the LiPV, it sort of does a 3D merged image. But yeah, for meibography, as long as you have an infrared source, you're good. There's a lot of devices that you can sort of slit into the slit lamp, and you can take the images. There's even sort of 3D printed. There's mobile attachments, things that you can have for showcases infrared. So most important thing for me to pass the message across is that Meibography alone, it is not sufficient for us to say, yes, there's dysfunction of those glands. We need to look at how those glands work, the secretion and the lead that we've just assessed before. So we need to look at all of this at once. Sometimes, for example, in my case, I have very long glands, pretty much like this patient in here, but they don't produce pretty much any oil, versus I have patients with this amount of glands and they go along fine, they have no issues, and they have oil secreting. So it is, you always need to take an approach of being careful, just looking at what's happening. Maybe the patient doesn't have any symptoms, but maybe there's something in there. So always educate your patients. So we have a proposed grading scale for Meibomian gland dysfunction, again, by Arita et al. So things that we need to look up for: vascularity within the lid, plugging of the glands, lid margin irregularity, changes in that thickening of that lid, which we've just seen in the image before, and the glands, if they're partial, if they're not partial, and if there's a gland dropout. This is yet another grading scale that you can use. The most important thing is that you're consistent with your grading scales. Whichever one that you want to use, make sure that you're consistent with that, or your practice is consistent with it. And then in terms of the expression, there's also different grading scales. So this is the Meibomian gland secretion score scale. So this one, you use a what is called a Meibomian gland evaluator or expressor. And what you do is you put it against the lid and you press for about 5 to 8 seconds. And that will sort of show the amount of oils coming up. And I normally do it 3 times to get 5 glands on the temporal, central, and nasal area. And then you grade each of those 5 glands. So you've graded from 0 being no secretion, then 3 being clear oil, cloudy, or inspissated. Inspissated is pretty much like solid. Then you add those up with a maximum of 45, 45 being the best. Very, very clear oil with all of the expressed gland, and a lower score would be that's not working too well. Other grading scales like Meibometry, we have this one. Let's see. So in here, when I'm pressing, I'm looking into the quality of those oils. Here they are quite transparent. Actually, they're not cloudy at all. They're transparent. So this, in terms of the quality of the 8 glands that I've expressed there, that would be clear for all of them. And the number of glands that I've expressed, actually, all of them were expressing. So that would be a 0. And the amount of oils, the pool of expressed oil, it was quite big, actually. So I would probably say 0 as well. So this patient will actually be quite good. So that's a Meibometry scoring. We just need to make sure that you use a specific device for that. So in this case, I was using the Meibomian gland evaluator. You can, if you don't have that, you can use digital pressure with your thumb just to press. Make sure you don't put too much pressure, because then it's not going to be the reality. But that's the diagnostic tools for understanding the scoring. And then the diagnostic tests that we're going to use are, as we've said, looking onto the lid margin, expressing, and the tear film changes and the blinking. That will sort of help us go from a more mild to moderate to severe approach, knowing if there's changes in secretion from 4 to 7 to 13, changes in the pattern of the lipids, going from a normal pattern of oils to absent or abnormally colorful, and also changes on that lid margin, so lid margin dropout or displacement. So those are tests that we're going to do to sort of help us with that. And obviously, the Meibomian gland images, the Meibometry, the Meibography. So how we can perform those tests, right? Start with the most basic, slit lamp. With the slit lamp, we can do lipid layer thickness with Purkinje 1. We can do expression. We can do lid margin assessment, but we also can add attachments. Attachments such as the Easy Tear View, which can help you with the viewing of the lipid layer, and which could help you also with the breakup time and even fluorescein assessments. There's other attachments such as the Maycam and Mecam, I think that's the name. Those ones, they actually are infrared sources, and they have an infrared detection, so you can actually take Meibomian gland images through those devices. And again, they're just attachment for the slit lamps. And nowadays there are more new attachments that you can also add to your phone. So this is a specific one that it's quite new actually. This one is basically based on reflecting those placid discs, so you can still understand the shape of that cornea and assess the break-up time. And then there's obviously other devices that can help you with the break-up time, the tear meniscus height, and even Meibomian gland assessment. So there's some like this one that you just draw along the line, and they'll tell you the automated amount of dropout of Meibomian glands. Some others that is not as automated, but you can still grade it on your own, such as the K5 or the Med1 Meridia. And then we have the LipiView. The LipiView actually assesses not only the breakup time, the lipid layer thickness and the blinking, but it will actually image those glands for you with a very high quality image. We also have the Antares, and this one as well, it gives you an automated grading. So you just have to draw along the lines. And now there's other devices that they've not been specifically designed for the diagnostics, but could actually help on the diagnostics of Meibomian gland dysfunction. So some people studied and used OCT. So that's sort of like the inner part of the lid, and you'll see the hollow areas are the areas where the gland would be, because it would be filled with oil. So that would be one test that could help us. And also IVCM, which is in vivo confocal microscopy. That the only thing is that you have to be in contact for that, so you need anesthetic. And you actually need to do a bit of an inversion of the lid and be in contact. And that will take an image of that surface cells. So what we're seeing here, those are openings of the glands. And what happens when the oil becomes too viscous? We said that the duct dilates. So there's a dilation, and you can still see the normal ductule, but actually this is a lot bigger. And it gets to a point that you can even see fibrosis around that tissue. So IVCM could be a very good diagnostic tool to help us understand a bit more what's happening, or if there's any changes, even probably before it happened. So now we're going to move into the treatments. So we have to be very careful with what we read. For example, there's some areas such as the old Morphill's manual and the Wills Eye manual that says use a face cloth for 5 minutes or use baby shampoo. We know that these things we have to be very careful with explaining, and we have to be careful with the myths that they are within the society, because we know that a face cloth is not going to keep up with the temperature that we need. And actually we know that shampoo actually harms the goblet cells within the tear film, within the surface of the eye. So we need to make sure that we're aware of the new findings and always keep up with the evidence, because maybe we're actually trying to provide a treatment to a patient and actually we're not helping, we're doing the other way around. So things that we know is that certain specific patients, the patients that they have an issue with the lipid layer thickness, they will be more likely to have a benefit if we actually use a lipid-based product. Aqueous deficiency patients, they could still have a benefit, but the ones that they'll definitely have a benefit, those are patients that they have issues with that lipid layer component. And then we need to double check that they are actually doing a good hygiene of those lids and lashes, only because we could have a bacterial overload. So either by wipes, by phones, by sprays, we need to make sure that they are consistent on that, just to prevent that possible hyperkeratinization of the tissue. And then lots of thermal devices. So we started with warm compresses, and now there's all these new fancy devices that you can still use while you have your eyes open, such as the Blephesteam, Tear Restore, Tear Care. So there's a lot more devices that they are prepped to reach the desired temperature. But what we know is that we cannot use face cloths because it's not going to reach that temperature. And maybe then the patient will start being less compliant, because if it doesn't reach and actually does the treatment, what would be the point? And then we have other heat and massage treatments by either debriding, expression of the lid, by removing any possible debris or demodex or blepharitis. And then we also have the expression. This is versus the other one. This is the therapeutic expression. So what I'm doing here is I'm forcefully pressing all along to see the oils coming up. In this case, we have clear oils coming up. And what we need to do is we need to make sure that we have a rigid object behind the eyelid to then be able to express, either with forceps, as I'm doing there, or with a metal paddle and then rolling a cotton bud or your finger, whatever it is. But what we're doing here, so the first one, the one that I just showed, it was the clear oil. Now in here we have cloudy oil, so the same thing. So in here, what we try actually to do, it is a treatment in itself, because if there's anything blocking, what we're doing literally is we are blocking those oils from coming out. And if there's any blockage at different distal areas of the gland, we would be removing that. And this is the more inspissated, the more solid look of those oils. As you'll see now, when I express, instead of being flowy and nice, as it's been with the previous two videos, you'll see it's sort of like squiggling out. This means that those oils are a lot more viscous and they'll need a lot more time to sort of melt. And then this is a study that we did that I thought was quite interesting. So in terms of the treatments that we can give to the patients, pretty much all types of lids, or all types of glands, independently of their shape and their length, they all have a benefit with warm compresses. So even if you cannot provide any other treatment to your patients, get them started with warm compresses, because that melts the oils, which is the main thing that could start on blocking those glands, those oils. And the other thing is, we've realized that there's a correlation with the length. So the longer the gland is, the better the outcome of those oils coming up. And also with the tortuosity, the more tortuous, the less good those oils are when they come out. So also looking at the shape and the size of those glands, we've realized that most of the patients had complete glands, complete being more than 75% in length. And they were giving sort of like clear expression and maybe some more particular, more cloudy. The partial glands, which are the ones that they have only just a bit of gland left, most of them, they were inspissated or not expressing. And the minimal length glands, less than 25%, there's some expression, but most of them didn't have a lot of expression coming from within. Also, we have to bear in mind that not all the glands will express at the same time, so they need time to sort of get those oils back. So things that we know from that study is that the shorter glands react better to more invasive treatments. The width of the glands, when we look at meibography, does not influence the function or correspond with tear film parameters, and that the eyelid warming therapy, such as a warm mask, it significantly improves the quality. So that's at least the main thing that we need to do. And then if we move on to the more medication aspects, we can go into antibiotics, steroids, cyclosporin, all of that would be antibiotic to decrease the bacterial overload that we have on the lid margin, and the anti-inflammatories to release any inflammation that we may have if we do have inflammation in that lid margin, because we know that some types of MGD, we might not have that active inflammation. And then we have light treatments. The light treatments, such as IPLs, photobiomodulation, is not quite well understood why it is happening, why it is giving a benefit, but it seems like it is from our patients, and clinically we do see results. The hypothesis behind it is that it reduces those little blood vessels. It triggers those blood vessels, and it depends on which mask you're using. So for example, these masks each has a different wavelength. One is to reduce the bacterial growth, the other one is to reduce inflammation, and the other one to activate those oils. And then we have light and heat treatments. So the heat treatment, such as photobiomodulation, it acts by sort of stimulating the production of ATP within the cells. So at the moment, again, we do not really know how or why they're working. So at the moment, it's sort of like a bit of a gray area between the commercial and therapeutic sectors, but we know that it is working. And then we have other treatments, probably not as seen or as used. Some of those that I'm presenting now, they're recent new studies. So this is a Tixel study. What we have in here, this bit, it sort of like heats up very, very, very warm, up to 400 degrees. And then in contact with the skin, it does sort of like microablations. And that ablation sort of like tightens the skin. That's used for skin rejuvenation. But if we do it around the lids, it's thought that heat obviously not going to be 400. It's bringing that scar down onto like hundreds. That Meibomian will liquefy a bit more and actually eradicate some of the demodex mites. Again, there's some studies that they're being done on this to understand its efficiency. And then there's another one that I found out about using a specific type of YAG laser to sort of like create. It's not an abrasion. It's not ablative, but it's sort of like a small type of abrasion. The idea is similar as probably the other one, to conduct heat, but to a deeper tissues where it's targeted, to actually change the components of those glands. And then we have other treatments such as probing. That's again, it's very intense. Those are new procedures that they're used. Some of them, they have not been proven yet. I just thought I would share. And this one, basically, they just probe within the gland to remove any fibrosis from within and to help unblock any possible blockaging on those glands. Now, in terms of what the report in 2011 on Meibomian gland dysfunction did, is once we've done all of this, we've graded what our patient has. If our patient's more mild to more moderate, that's when we can look into the management. The management would be starting with a mild stage with more of a diet, more so in the environment, looking into the evaporation, and consider eyelid hygiene. That would be the very first stage. Even just education, even if there's no symptoms. After that, when there's mild symptoms and some clinical signs, then that's when we start advising more humidity, a good amount of eyelid cleaning, eyelid warming, and then lubricants. If there's a case of inflammation, then we'll see if we need to add, or any bacterial overgrowth, we'll see if we need to add any antibiotic. And then if that doesn't work, then we can try all of the above with more heavy lubricants, as in more viscous lubricants, and then anti-inflammatory therapies if required. And then with the more sort of like severe staging, we actually use more of an anti-inflammatory specific type of medication. And then in terms of the conclusion, basically, we just need to make sure that we look the patient as a whole. We look at the lid margin, at the changes that is happening there, which can give us plenty of information, the lids, if there's any bacterial overgrowth, the changes on vessels, the shape, the size, looking also at the tear film, looking at the Meibomian glands, if there's any dropout, at that blinking, looking at all of that gives us plenty of information. And then something that I always do, grade. I always grade everything. I want numbers. So if I have a number on the first visit and then I give a treatment, I want to make sure that that number is going down. So you always need that consistency. Assess what your patients are feeling, if there's any risk factor, environmental or otherwise, that you could actually help them with. And once you've graded those patients, make sure you follow the algorithms for this disease. And that is all for me. I would like to thank everyone for your attention, and I'm open to take questions.
Thank you so much, Dr. Sònia, for sharing that with us. I think you did cover from the anatomy until the management. So you did cover entire as we promised on Meibomian glands. So thank you for doing that for us.
No worries.
Great. So I think one question which came in earlier was, probably you did mention about this as well, but how much is the temperature requirement to heat up the Meibomian glands? I think you did tell about this as well.
Yeah, I didn't say the specific number. So, but normally it's about 40, 41-ish. So you need to make sure that you get onto that level of temperature for those. I mean, there's not specifically regulated time, rather than time is for how long you have to be using your mask for. Ideally, people said once or twice a day for 10 minutes. But again, there's no specific regulating thing saying this is what you need to do. We need to do a lot more research in that. But what we need is we know that we need to reach that temperature in order to melt those oils, because without it, the blockage could still be happening. And one of the things that I tell my patients is, after you use that warm mask, do sort of like a rolling massage, or like, when babies cry, sort of like that. That tends to help the oils from once they are liquefied to be able to be released. Because otherwise, if you hit them but you don't massage them, maybe they will become stagnant again. So you need to make sure that actually you are helping those oils to come out, to be released.
Right. So we have to tell patients that it is more of a long-term thing that they need to keep this doing, rather than just do it and they feel good, then they stop it. So I think that's
that's the thing. Most of the time, they don't feel a specific benefit. Because again, with MGD, we have a lot of people that they are symptomatic. So you need to make sure that you explain and you educate them, because most of the times, if they don't know about the condition or what they're having, they'll just, they won't really be compliant otherwise.
That's right. Yeah. Let's take another question, which is here up on the screen. What about the gland dropouts? Have you seen reversal of gland dropouts in the practice? Do you have some thoughts over that?
So that's a very interesting question, and I was expecting that question from coming up. It's a tricky area. So it depends, because there's certain studies that they say, oh, after this treatment, I've seen this much regeneration. I think that we need to be very careful with the words that we're using, because one thing is regeneration, the other one is reactivation. So the fact that we had a gland that now is a bit more atrophied or sort of like shrinked doesn't mean that it cannot be reactivated. Now, regeneration is a definition where you actually create something from zero, or regenerate something that wasn't there to create it from scratch. That's a different story. With the treatments that we have, I think that we can reactivate by heating and massaging. I think we can definitely reactivate. Regenerate is quite complicated, but it would be on the realms of regenerative medicine, where you actually have to get specific stem cells, then transform them onto the cell that you want them to become, and then that would be more a regeneration. Reversing the gland dropout, I think we can reactivate the glands, the tissues from working. But now, if everything has dried up, I'm not sure yet, because there's no specific treatment for Meibomian gland dysfunction, but there's certain medications that tend to help with certain specific disease, or the production of certain specific substances.
Right. Okay. Another question is EI treatments. Have you heard about something like that in terms of managing?
I presume that's the IPL device, the one with the gel, I think.
Yeah, probably. So, if you can clarify, what is EI treatments? Is it something to do with the IPL or any specific?
I think it might be that. If that's the one, it's basically an IPL. So the IPL basically just flashes light along the cheekbone to sort of stimulate those glands from working. So that's the idea behind it. So all IPLs, I think that we have to be very, very careful with which patients do we actually pick for. Because if we put everyone on IPL, we might not have a benefit. We just need to find the patients that they actually have that telangiectasia, that they have those blood glands, that they have an inflammation in the lids, that they have rosacea. All of these patients, they will have a benefit from IPL. Not everyone does have a benefit straight away. And again, it does take a couple of sessions. So patients do seem to, if you tailor the patients for that treatment, they seem to have a really good benefit.
Right. And when we talk about the changes in the Meibomian glands, anything, what would be the duration or any evidence in terms of the changes will only occur after, let's say, 2 weeks or 4 weeks? Is there any particular evidence in terms of the duration?
Yeah, so there's a couple of studies that say for how long they've been, the results are there. Now, the issue is with some of the studies, especially with worm compresses, you need to be constant. So you can, it's not just sort of like a drop that you just put it and that's it, and the treatment's done. So you need to make sure that that treatment's consistent, unless on the study they've done it for 2 weeks and then they stop. So actually during my PhD, I've done that. I've used a worm compresses for 2 weeks and then I stopped. And even with the patients that they started with the worm mask and then they stopped, even after a month, they still had benefits. It was symptomatology benefits rather than what I was seeing as an eye care practitioner. But at least for what I've seen in one of my studies, we had a benefit for after a month. But we need to see, there's plenty of other studies saying for how long and which are the changes.
Right. And another question is, let's say the patient could not afford the in-office treatments and we want to, prescribe home worm compresses. What would be your suggestion for your patients? Do you have any clinical tips? I know you did go through a few, but if you could just reinitiate that when it comes to home-based worm compress. Yeah.
So first of all, education and environment. Environment, it is key. So if you work in an environment that is polluted, that there's a lot of dust, that there's no humidity, that will affect the surface of the eye, the ocular surface, and possibly the Meibomian glands. The idea is, first of all, to change the environment as much as we can by either using humidifiers or taking more breaks from digital devices, doing things that the patient can do. So that's on the patient side. Then in terms of worm compresses or treatments in office treatments tend to be a lot more expensive, but a worm compress is something that it's cheaper than, let's say an IPL could be on the hundreds of pounds or dollars versus a worm compress done daily. There's some compresses that could last you they have like 200 uses, so you can use it probably for a year. So those long term, they're quite more affordable. So I would say probably start with worm compress instead of just going full on for the treatment if your patient cannot afford. And the other thing is that we know that if within a month of using worm compresses or any other treatment or drops, the patient does not feel a benefit, a symptomatology benefit, then you can change to the next treatment. Like this, you sort of have a more of a turnover of the patients, and you understand if one treatment's not working, let's move to the other one. So I would start with the environment, then go for the worm compresses, make sure that there's a good lid hygiene as much as they can, and then heat and massage. They can do it at home after the heating with the worm compresses. So yeah, quite easy to do.
Right. Yeah. And in terms of the Tixel device, do you have any idea or opinion of this device in the management of dry eyes? Somebody wants to know if you have any experience on that.
Yeah, so it is quite new. There's been probably 1 or 2 reports out from probably the last 2 years. There's not a lot of evidence yet. I would just showing like new technologies, probably things that we might expect. I haven't tried it myself, but obviously there's sort of like this micro burn, and some of the hypotheses are sort of like quite controversial. One is thinking about the warmth that it gives to translate onto the skin, versus probably my hypothesis would be more onto the collagen reactivation, because of that tightening of that skin, that tightening, maybe that helps with the output of the oil. So opinion on textile device, unfortunately, I haven't tried it myself, so I don't know for sure. But I'm just waiting for new research to come out, and then maybe I can explain it to you again. Who knows?
Yeah, great. So I think with that, we know that a lot of things is happening in this space in terms of diagnosis and management. So it is an area where people are researching and new devices are coming in. So hopefully we'll have some answer to that soon.
Hopefully.
Okay, just taking one more last question, Dr. Sonia. This is to do about the warm compress again. Somebody wants to know if you have any experience on using the green tea pack warm compress. Probably it's a type of warm compressing device. And do you think there would be any benefits? Or maybe if you want to generalize on different, warm compress methods, anything in that line?
Yeah, so at the moment, I'm not too sure which one that is, if it's a specific compress from a specific company, or if it's actually a tea bag, because I actually had a patient warming tea bags and putting them on the ice and thinking that would get the treatment done. I was like, no, because it doesn't reach a temperature and you can burn yourself. So hopefully that's not the question. So in terms of warm compresses, yeah, there's multiple ones. There's some that they use warm heat. There's some that they use dry heat or moist heat. It depends. What we need is those glands to reach the desired temperature, which is about 41 degrees-ish, to get the oils flowing. Eyes open, eyes closed, that will depend then to the patient. But there's a couple of studies that showcase which warm compresses hold the temperature for how long, and is a comparison in between themselves. So if you want to, I can send that across. It's not none of my study, but I think it's quite good, at least if you want to compare different warm compresses. And yeah, at the end is you want to make sure that treatment, that temperature is given to the right time and the right temperature. And then it would be up to the patient if they don't mind having the eyes closed or they need the eyes open while they're doing things. So there's things such as tear care, tear restore, things that you can still have your eyes open while having the treatment.
Wonderful. Yeah. So I think with that, thank you so much, Dr. Sonia, for sharing everything about Meibomian glands and also, giving your opinions on the questions. So really appreciate your time.
Thank you very much. Thank you, everyone, for attending.
Yeah, we do have a session planned over the next weekend. So until then, take care, be safe, and see you around. Bye-bye.
Thank you, everyone. Bye-bye.
Thank you, Dr. Sonia. Bye.
Thank you.